So first we're going to talk, Shadab Rahman has kindly agreed to, all the way from the States, he's going to be telling us a little bit about his work, which has had a dramatic effect on falls. I'm going to put Professor Shadab Rahman's details in the chat so that you can find him rather than me talking about it, because we've got a lot to carry through. So thank you very much indeed, Shadab. I will turn my camera off now.
Thank you, Dr. Shelley James. It's a privilege to be here, and especially following Dr. Russell Foster. I echo everything that he said. I will be presenting some of the work that we've done in a few different settings related to clinical care, and starting off with a recent study that we completed looking at the impact of upgraded lighting on falls in care home residents. I have a few disclosures, so I'll just give you a minute, but nothing directly related to the work that I'm doing today or presenting today. Okay, so in a survey back in the 80s, it was shown that we spend about 90% of our day indoors. And obviously, when we're indoors, we are illuminating the area primarily for vision so that we're safe. But that has created a problem, which is our built environment in contrast to the natural environment that we have evolved to. So typically, in a daytime setting, we are exposed to about 300 photopic lux in an office setting, for example. And at nighttime, indoor intensities are around 50 to 100 photopic lux. But if you compare it to what we have evolved to, what our physiological system responds to, in the daytime, we would be exposed to about 10,000 lux of light, whereas at nighttime, we're done at about less than 1 lux. So essentially, we have changed the contrast between night and day by orders of magnitude. And we've created this problem where we have dim days and bright nights. We know from various different studies, both in the laboratory as well as in the field, that visible light exposure induces a wide range of physiologic responses in humans and animals. From gene expression to protein expression, changes in hormone levels. Perhaps all of you have heard about how light affects melatonin. It suppresses melatonin at night, but there are various other hormones, cortisol, reproductive hormones that are altered by light exposure, and then all the way up to overt behavior. And there are various different names that we give to these responses, but they can be broadly classified as non-visual responses to light exposure. But again, these are physiologic responses that are happening with exposure to visible light. So how do we overcome this problem? And the objective is rather simple. We need to go back to the sort of contrast that we had, that we evolved to, essentially have brighter days and dimmer nights. And I would like to stress, and Professor Foster has touched on this, and I'm very grateful for that, we must have evidence-based interventions. We can't just pull things out of the hat and say, oh, I think this will work, and then we just throw it in there. We have to have hypotheses and test hypotheses. And I love what Dr. Foster said, which is, we can't go in there to prove a hypothesis. We have to test the hypothesis. And so our interventions must be based on evidence. And over the last few decades, we have collected a lot of data, again, both in controlled laboratory studies as well as in applied field settings, where we have tested different characteristics of light exposure. For example, wavelength, the spectrum, the intensity, the duration, pattern, timing, history, etc. And we have a fairly good working understanding of how these different characteristics affect physiology. And so we can take that understanding and develop protocols and intervention to improve overall health and well-being. And so something that, a very, very simplified guiding principles that we use for designing interventions, we essentially dichotomize the objective. Again, as Professor Foster says, it's not one size fits all. So depending on the situation, if you're designing lighting interventions for environments where people are not sleeping, and it's primarily designed for work and performance, you want to have high intensity blue and rich lighting, essentially giving a stronger melanopic input to the system. Whereas if you have an environment where people will be sleeping as well as working, so for example, care homes, then you want to have a tunable system, and I'll put tunable in quotes, because it doesn't have to necessarily be a very fancy system. Essentially, all you want is the lighting intensity in the spectrum to be changing throughout the day so that it better matches the physiology that we have. So with that very simple model in mind, I'll jump into a few applications that we recently tested, starting with falls in care homes. So falls in older adults is a major concern. It's a health concern, it's a psychological concern, and it's a burden not only for the care providers, the economy at large, but also for the individual going forward. So 1 in 4 adults fall each year, at least in the US. And then older adults, it costs a lot. It costs about $50 billion per year. And then it leads to 3 million emergency ED visits per year. And in the last decade alone, the rate of falls have increased by about 30%. So it's a major concern in the aging population. And there are multiple risk factors that are associated with falls. And so typically, if you want to do an intervention to reduce falls, it has to be a multi-component intervention. And various different interventions have been tried and tested. So, patient education, changes in lifestyle, changes in environment, and often changes in environment do include changes in the lighting environment so that people can see better. But often these interventions are broad and complex, and there are many, when you try to actually implement them, there are many barriers that come up. So can a passive intervention such as implementing a dynamic lighting schedule work? And that was the hypothesis that we tested. So we know that lighting interventions affect various different risk factors associated with falls. So for example, lighting interventions improve sleep, improves the duration and quality of sleep, it improves mood, it improves activity and cognition. And these are all independent risk factors for fall. So we essentially asked the question, can lighting interventions, specifically implementing a dynamic lighting schedule, improve fall risk in care home residents? And the way we did this study, we worked with 4 different care homes, a pair from each company, and we collected data for 12 months before the intervention occurred. And then post-intervention, we collected another 12 months of data. And the way we did the interventions was that in each pair of care homes, there was 1 control site and 1 experimental site. And so that gave us in total 2 experimental sites and 2 control sites. And just to give you a background on the demographic of the population, so pre-lighting upgrade, the control sites and the experimental sites were very similar, mean age of around 83, 53% or so women, and then the level of dementia was similar, or the prevalence of dementia was similar between both populations. And then also post-lighting upgrade, by and large, they were similar, except for dementia, there was a significant increase in dementia in the experimental side. It's just that the population was slightly different. It's not that the lighting caused the dementia. So nonetheless, what was our lighting upgrade? The control conditions essentially had static lighting schedules. So in other words, from midnight to midnight, the lighting levels never changed. And if you look at the photopic lux, that's the solid line here, it's around 150 photopic lux all throughout the day, the 24-hour day. And if you look at the melanopic intensity, melanopic EDI, it's close to around 70 melanopic EDI. And then, so this is in the common areas. And in the bedrooms, you see much lower lighting levels, photopic lux of around 70 to 80 melanopic lux all throughout the day. And then, so the experimental condition, essentially what we tried to do was create dimmer nights and brighter days. And so you can see this graduated change that occurs throughout the day. And we're using standard off-the-shelf, readily available commercial products, nothing special, 3000 Kelvin blue depleted lamps for the evenings and nights, and 6500 Kelvin blue enriched lamps for the LED lamps for the daytime. And that's, you can see the dynamic change in the common areas as well as in the bedroom. And by and large, so what we did was we increased the lighting levels during the day by about 73% in the common areas and about 65% in the bedrooms. And at night, we decreased it about 83% in the common areas, and 33% in the bedrooms. So now, what was the impact of this on the primary outcome, which was falls? So before the lighting upgrade, you can see that the rate of falls were very similar between the control and experimental sites. And they were very close to the US average. So about 7 falls or 6.8 falls per 1,000 patient days. Now, following the lighting intervention, you see a significant reduction in the number of falls or the rate of falls in the experimental sites, and a slight but not statistically significant increase in the number of in the rate of falls in the control sites. And what this amounts to is that there was a 43% reduction in the risk of falls following the lighting intervention in the experimental sites compared to the control sites. So these results were very encouraging from the fall perspective. But then we also had Pacific Northwestern Laboratories in association with the Department of Energy in the US do their own independent assessment of the energy savings that resulted from this lighting intervention. So the conversion from standard fluorescent to LEDs. And essentially they reported that by and large, there was about 60 to 70% reduction in energy usage by switching over to these LED. And you can see the breakdown in the component of just from the amount of energy savings from LED conversion versus what's coming from, you know, the additional savings that comes from the dynamic schedule where you're dimming the LEDs in the evening. And you can see this full report, which is published online. So what we find essentially, it's a win-win situation. You're improving the rate of falls from patient outcomes perspective, but also from the facility side, you're having major savings in energy. Okay, I want to switch gears slightly and look at another study, because you know the primary outcome for that study was patient outcome. But what about the providers? So we did another study where we focused on medical errors. And in this case, you know, medical errors are of concern, again, to the economy as well as to the patient, obviously, but also to the institution and the care providers. So it's very expensive, as I said, but more importantly, it's associated, at least in the US, with about 200,000 deaths annually and over 1 million injuries due to medical errors. And we and others obviously have done a lot of work showing that you know, sleep is a major component, lack of sleep, I should say, is a major component or a risk factor for increasing errors in medical errors in care providers. So this was a study done with the University Hospital, with the University of Wisconsin. And in this particular trial, what we did was we changed the lighting in just the nursing stations and looked at the impact on, or examined the impact on medical errors. So it was a single site study, 6 months with a 6-month baseline and then 6 months immediately following the lighting intervention. So initially there were fluorescent lighting, and then we changed them out with LEDs, and the lights were essentially, we went from 61 melanopic EDI during the evening shift to 208 melanopic EDI in the, also during the evening shift. And we collected medical errors from 1,073 ICU admissions, 5 months per condition. And over those 1,073 admissions, there were a total of 302 errors. When we analyzed the difference in the error rates between the two, what we found was there was a 6% reduction in medical errors, which did not reach statistical significance. Neither did potential errors, but there was a 10% reduction in potential errors, 13% reduction in harmful errors. However, there was a statistically significant reduction of 33% in high severity harmful errors. So taking the two sites together, implementing lighting interventions, a dynamic lighting schedule for the residents who are sleeping and active in the care homes, you see a reduction in the rate of falls. And then if you specific lighting intervention for the care providers, which is not dynamic, because again, like I said at the start, we want to keep things simplified and to maximize alertness and proactivity and safety for the workers. We want to keep them active at night, and therefore we're just increasing the melanopic content of the light and giving them brighter blue and rich light during the night shift. And we see that there's a significant reduction in medical errors as well. Okay, I just want to quickly touch on my last study, which is to show that this can be done in residential settings as well. So again, this was a lighting intervention study of dynamic lighting schedule in a residential setting where patients with mild traumatic brain injury were being treated with the standard lighting that they had in their homes versus implementing a dynamic lighting schedule. And I want to point out again that the dynamic lighting schedule was created very simply using off-the-shelf product where we weren't putting in fancy controllers or anything like that. It was, you either have a dim table lamp with blue depleted lighting that you would turn on during the day, during the evening, whereas you would have brighter lights just coming from your, overhead lighting or other lamps in your room. So a very simplistic approach. It was a crossover design, so a small pilot trial with only 24 individuals, and but essentially they had a baseline, then they did treatment with the dynamic schedule, or they had a control and then a follow-up, and in the reverse sequence for the second group. So again, just to highlight the difference, I'll just focus on the melanopic EDI. The control condition was pretty high to begin with, but nonetheless, we made it higher with the treatment during the daytime. And in the evening, you see the major change where you're going from a high melanopic EDI in the control condition to a lower melanopic EDI in the evening. What are the outcomes? We assessed sleep quality essentially with the Pittsburgh Sleep Quality Index. This is a questionnaire that individuals can fill out and they can report their sleep quality, and a lower score indicates an improvement. And so we see that with the implementation of the dynamic schedule, there is an improvement in sleep quality. And then once you take the lighting intervention away, because remember, this is a crossover design, you can see that you lose that improvement in sleep quality, and in fact, it gets worse over time during the follow-up. The other measure that we had was the Insomnia Severity Index, and this is a measure that's used clinically as well to assess insomnia severity, how bad a patient is experiencing their insomnia. And again, you can see that with the lighting intervention, there's a significant reduction in their ISI scores, or in their insomnia severity. And then once you take the lighting intervention away, their insomnia severity worsens. So essentially, these are three examples where you can use lighting interventions, which are implemented based on evidence, but more importantly, content and context specific manners, and you can see improvements in health outcomes. So just to finish off, I think, again, Professor Foster has touched on this, and I agree with him that the timing is right, and there are various different opportunity spheres for us to test this and optimize these different lighting interventions. There's obviously the residential setting where we can look at outcomes such as sleep and circadian health and overall well-being. But similarly, we can test this in the commercial settings and in the clinical settings. All of these are very attractive avenues for testing. However, I want to, as Dr. Foster did, I want to stress that we do need to test them because we want evidence-based interventions. I'd like to thank a whole host of individuals, my colleagues, my institutions, and the funding agencies. And I'll leave you with a simple proverb that says, when you shut out the sun from coming through the window, the doctor comes out at the door. So with that, thank you very much.